Dr. Marty, welcome. Thank you so much for doing this, and tell everybody your story and what brought you to me in the first place.
Thank you very much, Dr. Horwitz. Good to see you again. Sure, I'd be happy to. Basically, I have been a runner for many, many years since I was in my early 20s. In my training, I'm a pediatrician. And I think running has been just a lifesaver to keep me healthy and keep me going. As of a few years ago, I noticed in my left foot that I was getting pain right in between a couple of my digits in my smaller toes. And it turned out it was a Morton's neuroma. So it was diagnosed and confirmed and whatnot by a local podiatrist. And so I said, well, what can be done? He said, well, you have a number of options. The most severe being go in and have surgery and actually cut the nerve. And I didn't like the sound of it. I did my research as I always do. And I just thought that was not a good idea because of problems later on. You can get pain again as the root of the nerve comes back. It just doesn't sound like a good thing. So I opted for just some injections, some cortisone, some pain control, some inserts. Anyway, nothing worked. It just didn't work. So I continued to research it. And I found that there was a procedure where you could actually freeze the nerve and that would take care of the pain and hopefully make it go away. Well, I'm out in California. I could not in my entire state of California find a podiatrist that was doing this. So anyway, I researched this procedure and I found you in St. Louis, which again is a bit of a distance for me, but I figured this is really worth it. And this is my toe and my running and everything else, and I need to do
You
this.
did? You mean you didn't
So,
want to run? You didn't want to run from California to St. Louis?
well, I would have if I didn't have the neuroma, it would have been optional. But I, you know, we had a consultation. I had a consultation with you, and it turned out that I was a candidate, and you were going to do this procedure. So off I went to St. Louis to see you, and it was just a wonderful experience. Your whole staff and everyone else was there for me. Everything ran smoothly. You assured me that this was a great procedure, safe. So we did it. You did the freezing of it.
So this is a big neuroma. I call this an earlobe type neuroma because it's real flat. It's been mushed out. It's really important to disconnect the neuroma from the side of the fourth metatarsal where a lot of the stickiness is you don't have to defasciculate the whole nerve, but you can disconnect the nerve from where it's traveling next to the metatarsal pretty easily without damaging the nerve. So I just now am tracking this nerve back to where the cryoprobe is, and I'm putting in the first of probably 3 or 4 freezes on this nerve.
And I came back home, and it took a while to kind of calm down a bit and get better, the swelling and whatnot. But it was only a short while after that I was back running, and with no pain, nothing. So I was just ecstatic, absolutely ecstatic. In fact, I told everybody else. I had other friends that had similar problems. I said, "You need to talk to you to give you a call and do a consultation." So I was thrilled. So I went, I just went about my running. I was excited to be back on the road. Then, as of about 2.5 years ago, I started developing really a lot of pain in my big toe in my other foot. And so I knew that right foot had given me some problems in the past, but I figured, oh, well, I can run through it. Well, it just got worse and worse. It felt like I was hitting bone on, bone was hitting other bone in that toe. I went to see the foot doctor, the podiatrist, and lots of x-rays, some injections also to start with. And it wasn't getting any better. It was harder to run. Things were getting worse. I was getting very frustrated with the whole procedure. So this podiatrist out here basically said, okay, I've got the procedure for you. We're going to go in. We're going to do surgery on that toe. And at the joint, I'm going to insert some cartilage. And I think it came from perhaps a cadaver I said, okay, you sure this is going to work? And he said, it's going to work. So anyway, I had the procedure, I had the surgery, and had a lot of swelling. And he said, just give it some time, it'll get better, and you'll be out running soon. Well, it didn't. It didn't get better. It, it might have even been worse. It didn't feel any better. Went back in after a while, continuously going back in, and he said, I don't know. It's just I can feel there's still bone on bone. I don't know, what's going on. And so he said, well, we can go back in and see what's going on, or just do a fusion. So a fusion for a runner is not something I wanted to hear, where my toe would be permanently fused together, and so that didn't sound like I'd have the mobility I needed to run, and I wasn't about to stop running. So once again, I called you because you saved me from my neuroma. I figured you probably have something else up your sleeve to take care of this problem. Sure enough, you told me as we talked about it that you do a procedure where you actually replace that whole joint, and I'll have the mobility, and it should work. So I trusted you, and off I went once again to St. Louis, and met with you, and you did the exam, and you said, yep, this is a problem. There's bone on bone. There's no cartilage really that you feel in there anymore. So we're going to do the surgery, which I did, and it was successful. You told me, actually, interesting thing is, after you did the surgery, I asked you, what did it look like in there? Because I had the first surgery where you supposedly put some cartilage. And you told me, you said it didn't look like anything had ever happened. You didn't see any cartilage. It was just I just had none of my natural cartilage. The bone was scraping against each other. And so you replaced that joint. And I figured this was a new procedure for me. Went back home. You told me to make sure I exercise it, make sure I have that mobility.
So this is what I want to just fill in some blanks, but this is a very patient-centric video because I want people to understand what patients go through in order to rehab themselves or get to the point that they can do their activities. I always brag about having treated a lot of athletes. I had a ice climber at one point with a neuroma. I've always wanted to do a video showing him climbing icy waterfalls with his neuroma. So you were a great patient in terms of your activity, and I knew that the cryo-decompression was the right choice. But I do want to fill in the blanks in terms of you had a very uneventful recovery, correct, with the cryo-decompression. In other words, the neuroma procedure went well, but you did report one thing, and we addressed it in the first video, and that was a marble-like feeling on the bottom of the foot. And the purpose of releasing the video, just so you all know, was simply to educate you and let you know that that marble-like feeling is normal. In fact, Dr. Marty helped me understand how normal it was. And now I tell all my patients that for a while, up to 4 months, you can have a little strange feeling in the bottom of your foot. But this is good news because this stuff goes away and allows you to get back to completely regular lifestyle in terms of the neuroma. And the second thing I want to update people on, I'm really working hard getting videos done. We are now doing the Morton's neuroma procedure with the smaller incision in between the toes. And so what this simply means is the healing's faster, there's less chance of dehiscence, and this was the procedure that many people reached for originally and were somewhat disappointed in when I said, you need to have a more conventional incision. And our incisions are now even smaller, and of course we're doing up to 4 of these a week. And the results are very consistent. So that sort of wraps up the neuroma. I'm really happy you did well with the neuroma surgery. And really, it's an honor to be trusted by another colleague. But now we're getting into the first metatarsophalangeal joint, and there's a lot of questions that are getting asked about this because both of these are very loaded subjects. Do I cut my neuroma out? I always say, no, you don't. Please don't cut your neuroma. You should never cut a nerve, and there's never a surgery that recommends cutting a nerve except for Morton's neuroma. So essentially, this was standardized as the standard of care in podiatry and orthopedics, and I just don't believe it's the best way to go. Decompression and freezing, for many reasons, and we'll have an updated video for this. Is the answer. So it's a loaded subject. People are scared. The same thing holds true with first metatarsophalangeal joint surgery, in that it's sort of a loaded subject because, believe it or not, the standard of care in the orthopedic and podiatry community is still fusion. A lot of people fuse, and fusion can be very effective, even for runners, as we touched on. However, you get loss of function, you can't lunge, and there are many people that reach out to me because I specialize in this and say, I broke my hardware, or it's still killing me. The toe was fused too straight. And these fuel fears of having this procedure done. I have done, as you can imagine, a ton of research on this subject, and have found some things, little blanks I want to fill in, and then I'm going to let you continue, because I just want people to understand, now that we have the opportunity to release this video, what is going on here with the subject of first metatarsophalangeal joint fusions versus preserving function and doing implants. In the late 60s, this procedure was developed by Dow Corning. It became super popular, and doctors were overutilizing it. They were doing so many of these for the wrong reasons. Many doctors who said this must be the answer for everything were putting them into bunions. Absolutely not a good idea. And so what happened is the overutilization led to complications. There wasn't also a standardized cook in the kitchen approach to doing this. It's not the simplest surgery, and you can imagine in the 60s and 70s, it was very new. And the Dow Corning implant, while being simple, there were a lot of questions, unanswered questions. So what happened was the reputation for the implant started to fall because of the fact that this procedure was overutilized. Then it started to even out, and people were using it for what it really was meant for. And then doctors who liked it started to refine their techniques. I was a doctor, very intuitive, as many of you know, that wanted to refine the technique because I felt it represented the best choice in terms of preservation of motion. But here were the factors. You have to put it in so that you run as little risk as possible. And there's videos that I'm releasing in the very near future regarding this subject, but you have to put it in with a technique that involves achieving the best range of motion, which means resecting out the correct amount of bone, skiving the bone, and I have Dr. Marty's x-rays, which we will put up so you can see how well we skived him, at the top to actually prevent what we call creeping fibrosis, which is a condition where people sort of fibrose the implant in and prevents a good range of motion. Now, many of you may know there's two component implants out there that are not like the solid implant that I like, the Dow Corning implant. And these two component implants, sometimes they work well and sometimes they fail because of this creeping fibrosis, that occurs when the toe is going through a range of motion. In Dr. Marty's case, I knew he was a runner, and I said, we're going to do the cook in the kitchen approach that I developed, where we skive the bone. And I'm going to point to little areas here that show where I skive the bone so you can see how the shape has changed, creates a little V in the joint to really, really free up the joint. And then we pack that skive with bone wax, which prevents bleeding, because bleeding can also lead to fibrosis. Here's the implant, here's the grommets. We leave the grommets out of the equation because I think if I put the grommets in, all that nice bone wax I put around the joint would get peeled off by the grommets. So essentially, it's very commonplace not to use grommets, but in my particular case, real important that we don't. If we come over here, we're going to take this implant. This is the actual implant that's used. And as you can see, all the surfaces have been bone waxed. And now we pop the implant in proximally. I'm going to shift over here a second and just try to very delicately. There we go. Get the implant in distally, and that's what we're supposed to have. This is very good prognosis here because the capsule's thick. We're going to close the capsule over the joint, and he's got a great range of motion here. Okay. Finally, Dr. Marty is going to explain that we shortened his second metatarsal. When you do a joint replacement, we replace the joint with a silicone joint, and it off-weight loads the foot to the joint next to it, the second metatarsophalangeal joint. And this joint is in danger of developing excessive pressure syndromes such as capsulitis or even a stress fracture if you don't reinforce it. In the case of Dr. Marty, I believe, and correct me if I'm wrong, I did reinforce your second metatarsal, which has allowed you to run comfortably.
I went home. I had some pretty good mobility, and you told me that there was during surgery that there was really excellent mobility of the toe. Over time, though, I was getting a little frustrated because I was having persistent swelling, and I was trying to do the mobility. The mobility really trying to move, flex the toe back and forth, and just so things don't get stiff and fibrosed. So I was doing that religiously, but it just wasn't working initially, and there was a lot of swelling. We talked about it, and again, like you mentioned, probably some effect of that first surgery, because that swelling never really went down. So on top of 2 surgeries, I was having persistent swelling. So I was getting a little frustrated. I remember sending you pictures, I think little video pictures on my phone of me moving my toe to say, does this look more flexible? And I mean, running, I could start back running probably within 4 months, and but it just wasn't where I wanted it to be. So long story short, I did go in for some physical therapy, some intense physical therapy, really flexing that toe. I was doing more on my own at home also to do that physical therapy, and now we're almost 2 years into this. It's very much comfortable now. I'm just having a little issue with picking the right shoe now, because I've lost a little bit of fat pads on below those metatarsals, and so that's been a little bit of an issue. But I did find some good shoes that
have you tried Newton's? Have you ever heard of Newton's?
You were telling me about Newton's. I found a shoe called Topo, kind of a new shoe. It has I need the very wide toe box, and so I wanted my toes to be able to splay out normally and not be crunched. Plus, they have a little bit of padding, and the drop is about 5 millimeters, and there's a little bit of rocking. So it's actually been feeling really good with these shoes.
Nice.
So again, yeah. So I'm really happy. So I just went running yesterday. I run maybe between 4 and 7 miles. I'm not doing any more marathons. I've kind of outgrown that, but I am happily running my.
Quick question: should you decide you wanted to do a marathon, just based on your foot at this point, could you?
I think I could, because when I ran the 7, or even a half marathon, I mean, I was thinking about it. It just takes a lot of time training and putting in those hours, and you really have to go slow.
It's a great point, though, to make. You not hide from it. Like, look, we're saying that you're going to have normal activity. That goes for 88-90% of the patients I see. But I get extreme athletes, unbelievable. Like, I've got a guy that runs, one of those ultra marathons, and it comes in with this because this is the people that get this. You want to know as a doctor. I always say no news is good news after I see a patient remotely, because you're seeing them remotely, and even though you have access to me, as you can tell people, you had plenty of access to me. I was pretty much answering your texts in real time, or close to it. And the reality is you have to do that when you do remote surgery, but you also worry, a little bit about how's that patient doing, and if they have complete access to me through secure messaging and they're not actually calling me, then we come to the conclusion that these patients are doing just fine. We're now reaching out to something like 140 patients who've had cryo-decompressions, and we're going to say to you, please be honest, how are you doing? And let people know, because I think people just need to know there's a better alternative. So you've done, you've done well, obviously. A lot of people that are skeptics online, are going to say, well, you showed your success story. What about your worst failures? It's like, no. I'm going to be very transparent about, when I get asked the question, What are your worst failures? You have to be prepared to give those answers, as you know, as a physician. You have to be not only perceived as being honest, but basically blatantly honest with your patients, especially nowadays, because communication is so important. So I know you commented on my staff. They've been with me for a long time, many of them over 20 years in the surgery center. You've had a good experience. Is there anything that you can say to people that you think we haven't talked about yet that needs to be talked about in terms of your experience with either procedure?
Well, the neuroma surgery, the cryosurgery was, kind of a piece of cake. It went very quickly. The recovery is faster. You have to just be patient. I think, being patient as a patient is
Right.
really critical. I mean, if you're not
I
patient,
preach that.
it
Right.
doesn't, yes, it doesn't happen overnight. It just does not happen overnight. But you have to do your work too. When you do your surgery, and then we have to do our work too to keep moving, to keep the flexibility, to be patient.
Thank you, Dr.
And it,
Marty.
yeah, and that makes all the difference in the world. And I would call me a success, but as I said, it took me over a year and a half, really, to really move on this flexibility issue. So
With the great
again,
toe. Yeah. And
yeah, with the
again,
great toe.
when people bring surgeries that have been botched, um, that is one of the hardest things to judge because, and I don't mean botched, meaning the doctor did necessarily anything wrong. I just simply mean the surgery itself did not go anywhere near to the point of the patient's expectation, and they're now have limited range of motion or continued pain. To comment just real quickly on what your options are if you have a limitation in the range of motion or pain in the great toe joint and you've been diagnosed with arthritis, bone spurs, joint thinning. There are, everybody has options, but the biggest problem that the doctor is managing is patient expectations and whether or not there was another surgery and what to do to help the patient make the decision to go with something like an implant, which is more one and done if it's done correctly, or what is referred to as a cheilectomy, or in your particular case, a surgery that's not done as often, which is cartilage transplants. And there's different ways to consider cartilage. There's the Cartiva implant, which is slightly different than possibly what your doctor attempted. But ultimately, when I speak specifically about the cheilectomy, this is a very common procedure. Doctors will take people to cheilectomy all the time. This is, and we'll illustrate it above, is basically giving your metatarsal head a haircut so as to remove the spur and improve the range of motion. I will tell you, as a very experienced doctor that does many procedures on the first MPJ, the cheilectomies are always temporary. It doesn't mean you can't do one, but the doctor should be very transparent, and most doctors are. If you're doing a cheilectomy, it's a temporary thing. You're lucky if it lasts 10 years, and then you're going to graduate to a first metatarsophalangeal joint implant. So there's no magic pill, but the real challenge is to determine how, based on the patient's age, what is the best course of action. And it's really interesting because young people are looking to, and everybody's looking to do the most minimal thing possible. There's just not a robotic, simple, arthroscopic way to treat this particular weight-bearing joint. So there's no simple answers, because what I'm referring to is you mentioned how simple the cryo-decompression was. It is. It could be very simple when addressed in a clear fashion. You have a positive Mulder sign, everything is great. But when it comes to first MPJ, it's not been figured out. It's wide open. There's many, many, many factors. And so that said, if your doctor says to you, you need a cheilectomy, be prepared for that to be very temporary and get a second opinion, because maybe a second set of eyes might say, no, you don't need a cheilectomy. It's not likely it's going to work based on what you want to do, yoga, whatever, in terms of being pain-free. You might want to go for something a little different. And so in your case, we had the problem of a surgery being done, scar tissue. The great thing about the implant is you can resect out the joint. Anything that's wrong with the joint, you can clean up. And if you know how to clean up the joint and you're a good cook in the kitchen and you get all these little tiny little factors handled, you end up with a great result. So I hope people that are watching this are comprehending what I'm saying. We're going to try to educate a little bit more, but basically what we're giving you here is a doctor who knows his stuff, who knows patients, and who's explaining that it does take a little bit of work. And I think you did a lot of work, to be frank, with your great toe joint. I don't know if people would be willing to do as much. Explain to people what exactly you did. You were lunging, right? Were you doing weight-bearing range of motion? How did this start? What help did you get from therapy to get the first metatarsophalangeal joint range of motion to where you needed to ultimately be?
Well, I was doing a little bit on my own before I actually went to formal physical therapy. So, you can take your toe and put a band on it and flex it, pull it towards you and do that. You can almost get up into like a downward dog yoga position and,
Right.
and bear down on that big toe. So it also bends it up towards forward to flex it. And so I was doing that, but I don't think I was being aggressive enough until I went to physical therapy. And then the physical therapist was really putting pressure on it and really moving it. And the cool thing is that he could do an angle measurement to see how much flexion I was getting. So I know
Nice.
I went in there initially. Yeah, I went in there initially with maybe, I don't know, 35 degrees when it was really stiff. And I left with him after. Now it took 12 visits. I was close to 70% of 70 degrees rather of angle flexion. So now it gets stiff in the morning. So like first thing when I wake up, I can feel it's kind of gone back to it being a little bit stiff. But then it once you get it to move and be flexible, it goes back to being flexible pretty easily if you just do your exercise in the morning. So you do some of those
Like
downward
any
dogs.
part of our body at our age,
Yeah.
right? Yeah.
Right. Exactly.
Yeah, exactly.
So you can't expect to be like a 20-year-old and just
Right.
it's moving, everything is moving the way it used to. But I religiously get up and I flex it and I move it. And then before I run, and he told me to do that also before I run, also to use some heat on it before I do that. So you could either do it in the shower or put a hot pads on it or something, and that makes it flex a little bit easier. But you have to do that. You have to do it. Probably the rest of my life I'm going to have to do that. But that's okay because it doesn't hurt. It flexes enough so that I can comfortably run, and I'm happy with it now. Especially now that I have those shoes that give me a little more padding and make it feel better.
There's a lot of variables, as I've said. We're trying to figure it out. And ultimately, this is, you have to first just be transparent and real with patients when it comes to these procedures. Fewer and fewer physicians are practicing heroics because that's just not in the playbook with the way insurance is, with the way the medical legal system is. You have to be very defensive with the way you practice, and you have to have good, clean communication. You're a great communicator. Obviously, you're a doctor, and it made things very easy. I want to thank you because I think we've covered everything we need to cover. I want to thank you, and basically don't come into me with another foot problem for a while. But it's great. You've just been a pleasure to work on, and I wish you the best. And if you do run a marathon, or I think I told you this, I'd made this request. I said, in your next race, give me some B-roll so I can show how Dr. Marty is like
Sure.
frolicking over the finish line. Okay. Well, hey, thank you very much. Thank you all. If you've watched this entire presentation, obviously it probably means you're considering having some sort of procedure done at the Feet for Life Center. So if you have additional questions, please follow our videos. Please like and subscribe. And ultimately, I'm looking forward to seeing more of you that are having similar problems. It's very rewarding to treat patients like Dr. Marty and to do the kind of work we're doing. And you all make it worthwhile. So Dr. Marty, thank you so much. I deeply appreciate it.
Thank you. My pleasure. Thank you.